in the internet. I will try to deal with them as much as possible in the next 20 minutes. So the first one, I should take the iodine supplements since I am hypothyroidism. You will be finding many naturally containing iodine sources or some potassium iodide. These are all some of the things which are available on the internet. So, but whether we should take it or not. The fact is that there is no need for extra iodine supplementation other than the recommended dietary allowances. Our recommended dietary allowances for an adult is around 150 microgram, and in pregnancy and lactation is slightly higher. So ATA suggests that we should not take any other extra sources other than the recommended dietary allowances, which can be met with our salt intake, iodized salt intake. So why does that recommends against using iodine supplementation is in diseased patients with diseased thyroid patients, there is chances of having thyrotoxicosis or due to hypothyroidism due to Jod-Basedow or Wolff-Chaikoff effects respectively. So the next one, I should use Himalayan salt as I am having hypothyroidism. This picture shows different types of salts from the rock salt, that is your Kallupu, Himalayan salt or otherwise the pink salt, the black salt which is rich in iron and sulfides, your kosher salt which is mined from underground mines. These are all some of the salt varieties which are available right now, and among them the Himalayan salt has been considered to have many other properties which is not present in our day-to-day salts. So one thing is that it contains naturally containing iodine, and that is enough for your supplementation. That is a myth which is surrounding it, but in actually if you see, other than the iodized salt, table salt which you are using, all other salt varieties are poor in iodine. You will see this table which iodized table salt contains around 20 to 40 milligram of iodine per kg of salt, whereas your Himalayan pink salt which is down the line which has only about 0.1 to 0.6, that is 100 to 600 micrograms in per kg of salt. So for a person with the recommended dietary allowances of around 150, he has to take around approximately 150 to 200 grams of salt, which is not possible in our setup, in the day-to-day practice. So if you say now iodized salt, that is this 20 to 40 milligram, if it is present, that will come under, if you take our regular dietary allowances of around 5 gram of salt, you will get your recommended dietary allowances of iodine of around 150 microgram in that 5 gram of salt. So that is how that salt fortification of in India with iodine, they have set some targets, like your at production level, it should have around, the salt should contain around 30 milligram of iodine, and at the consumer level it should contain at least 15 milligram per kg. So that is the thing. If this is there, you can achieve our recommended dietary allowances of 150 microgram. And when we are using our iodized salt, we should keep in mind that it should be added after cooking, because heat will destroy your iodine, and it should be used within 4 weeks, that is 1 month of opening the package. These two things, and it should be kept in an airtight container. So these are some of the things which should be, precautions should be used while using your iodized table salt. So the next one, I have gained 25 kilos in the last 1 year, and I need thyroid hormones for weight loss. You will find T3 supplements available for weight loss. These are all some of the ads which are found in the internet. But what does ATA suggest? That is American Thyroid Association suggests that we should not use T3 or T4 for weight loss alone. And it is said that even in full-blown hypothyroidism, the weight gain is only around 2 to 5 kilos, and the rest of it is due to multiple reasons. One of them is the calorie activity mismatch. There might be an underlying drug intake due to like your atypical antipsychotics, or your underlying Cushing syndrome might be there. These are all some of the other causes which are causing your weight gain. So the weight gain due to hypothyroidism is only 2 to 5 kilos. And the weight gain, as I told, it might be due to multiple factors like your hormones, proteins, diet, etc. And one good thing is the percentage of weight gain contributed by your hypothyroidism, that is this 2 to 5 kilos, will be completely reversed with the treatment of levothyroxine. And this is the one, it is easy to diagnose hypothyroidism clinically. Here we have a first picture of a myxedema patient where there is an alopecia with loss of lateral 1/3 of eyebrows, a pale face with a periorbital edema. These are all some of the features, but and the second picture is like your cretinism baby with protruded abdomen, small umbilical hernia, massive macroglossia, nasal blown hypoplasia. These are all there, but these are all rare things right now seen in our clinical practice. Why it is difficult to diagnose only with the symptoms, this hypothyroidism, is that this symptoms are all insidious in onset, that the patient does not know that symptoms are developing, and they are very non-specific, like fatigue, constipation. These are all non-specific symptoms which are occurring in hypothyroidism. So, and under rare presentation of some hypothyroidism, or I just want to mention some things like your precocious puberty, galactorrhea, pituitary mass due to, it looks like a pituitary adenoma, but it's actually due to a lactothyrotrope hyperplasia, ataxia, carpal tunnel syndrome. These are all some rare features of, rare presentations of hypothyroidism. And, but nowadays we are picking up thyroid, hypothyroidism earlier due to our routine checking, and we find most of the master checkup including a thyroid profile in their master checkups, that is, it includes, it should include at least a TSH, or otherwise preferably a TSH with free T4 to diagnose both primary and secondary hypothyroidism. So in ATA, what does that recommend is that the screening for hypothyroidism should start at around 35 years of age, and it should be repeated every 5 years. And this is the one common diet related, that is hypothyroidism and diet, that is I should not eat any cabbage or cauliflower since I am having hypothyroidism. And this list extends to, in the net, it extends to caffeine, and it extends to processed foods, gluten, alcohol, and much more. So whether to eat these things, first thing is that we'll deal with the common one, that is cabbage and cauliflower. That is cruciferous vegetables, when eaten in large quantities and in raw, can decrease your thyroid function due to the presence of your thiocyanates in it. But limited intake and taken very occasionally does not affect your that is your thyroid function. Better way is that cook these vegetables in a very well way, and that will break down the goitrogens, thereby preventing hypothyroidism due to these ones. As far as gluten it is concerned, it is not suggested, ATA does not recommend any gluten-free diet unless the patient has coexisting celiac disease. And this caffeine, it can be taken 1 hour after taking your thyroxine tablets. The other one is that, can I take millets as I have hypothyroidism? It is claimed that there are claims that sorghum and your pearl millets, these two types of millets can cause hypothyroidism due to the presence of goitrogens. But similar to that cruciferous vegetables, well cooked millets will not cause any harm to your thyroid function. So the other one is that a gym trainer advised me to take creatine supplements for relieving hypothyroid symptoms. This was one of the things which when I was searching for this topic, it stuck in that internet means that they have told that there are 6 reasons why thyroid patients should take creatinine. It is said that your creatinine is preventing your bone loss, weight gain, decreases in inflammation, etc., etc. But what does our FDA and ATA clearly suggest that don't use any form of supplements in these things, especially for thyroid disorder patients. The other one is here, I can reverse thyroid disorders just by lifestyle changes, that is mainly through diet and some exercises. Yeah, there are certain exercises like your yoga poses, like your shoulder pose, that is different asanas are available for increasing your blood flow to the thyroid, but it does not give us a primary treatment. Primary treatment is still your tablets. And in the diet forms, there are certain dietary supplements which has the capacity to increase your thyroid functions. These diet mainly contains iodine, tyrosine, with these two are needed for the production of thyroid hormones, and thyroid hormone containing supplements. That is your extracts, like your previously, before the introduction of levothyroxine, we used to treat hypothyroidism with animal extracts, sheep thyroids and cow thyroids. These are all used. These extracts, and there are certain foods which decrease the thyroid function, like your cruciferous vegetables, which has been seen earlier. Even though these are there, ATA and AACE recommends against using these diets and these exercise rich in nutrients as a first line treatment for hypothyroidism. They can be used as a supplementary just to help your things. The other one is that myth that is I am having hyperthyroid disorders and so I can't get pregnant. This is a wrong notion which is prevalent in the population. Thyroid disorders reduces the chance of pregnancy but never makes it to nil. We still in our clinical practice get hypothyroidism diagnosed during the first trimester visit. And it is known that a patient who is already on hypothyroid patient who is on levothyroxine during pregnancy, their dose should be increased by around 20 to 30% of their previous dose. The other one is that don't take thyroid medications in pregnancy. This is another one more myth. It is stated that your levothyroxine, which is not, there is not much controversy regarding this one because it's totally safe. Coming on to the antithyroid drugs like your propylthiouracil, carbimazole, methimazole, these are all used to treat hyperthyroidisms. They have some rare side effects like your omphalocele, choanal atresia, nasal bone hyperplasia, but these are all very rare and the benefits of taking these antithyroid drugs outweigh the risk significantly. In terms of managing hyperthyroidism in pregnancy, we generally use propylthiouracil in the first trimester and third trimester we change it over to carbimazole or methimazole. So the other one we have this one, that is I am having a thyroid swelling, so it is a cancer mostly. We see many anxious patients coming to our OPD with thyroid swellings and thinking that it is a cancer. Not all the things or swellings are cancer. Here you will see that first picture is actually thyroglossal 6, second one is a simple plain goiter and third one is a multinodular goiter. So there are many other causes for thyroid swelling other than your just thyroid carcinoma. These include like cyst, autoimmune thyroiditis and the other ones which I have mentioned in the earlier slide. There are some clinical features and some palpable features which we are able to identify which are suspicious for your cancer. We have to look for these things, that is a thyroid swelling occurring in a less than 20 years and more than 60 years and with a family history of thyroid cancer, with a history of exposure to ionizing radiations, a nodule which is very hard and fixed with associated lymphadenopathy. These are all certain suspicious features suggesting that it might be a malignant nodule. These are all present. We can suggest for further things like your ultrasound and FNAC if needed. I have thyroid carcinoma and it is not curable, and this is a picture of your metastatic follicular thyroid carcinoma with skeletal metastasis, bone metastasis. Right now, your differentiated thyroid carcinoma, that is your follicular and papillary, are one of the few cancers which have a very good cure rate. We have multiple modalities of treatment like your iodine 131 radioablation, suppressive doses of the levothyroxines, tyrosine kinase inhibitors given for metastatic carcinomas like sorafenib. These are all having good success rate in treatment. Medullary thyroid carcinoma is a little bit difficult to treat, but when it is detected earlier, it is also completely curable. You have an excellent biomarker for this one, like that is calcitonin, and for differentiated thyroid carcinoma, you have thyroglobulin. These two help in your prognosis and it helps in your course of treatment follow-up also. Anaplastic carcinoma is one of the variety which has a very pure cure rate and it has a very poor response to your chemo and radiotherapy. And regarding that, this one, the next myth, my symptoms have subsided with the treatment, so I can stop the thyroid medication. This is a book which is found in Amazon, which is tell that she had healed with your holistic approach of your yoga, Reiki, mantra, and crystals. So these are all some of the things which have been used, but just make sure that we cannot stop the medication in all cases, but in certain few cases of thyroid conditions are temporary, like your subacute thyroiditis, anti-TPO negative subclinical hypothyroidism with symptoms. These require temporary treatment only. Even Graves' disease with grade score of 1, class 1, they will need treatment only for around 2 years approximately. Others, in most of the other conditions, there is need for long-term or maybe lifelong therapy also. So don't stop your thyroid treatment without your endocrinologist advice, and don't follow the other alternative approaches given in the net. Thyroid disorders affect only women. yeah, thyroid disorders are more common in women than in men. Both hypo and hyperthyroidism, thyroid nodules, these are all more common in females. This is one picture which is found, which is from British Thyroid Foundation. A patient named Dave, before just at the diagnosis of hypothyroidism and after treatment with levothyroxine, you could see palpable changes in their facial features itself. It was late diagnosis, so he had all these features also. So the next one, I don't want to take GLP-1 agonist due to the risk of thyroid cancer. GLP-1 analogs like your right now oral and subcutaneous have come with dual agonists are also available right now for treatment for diabetes and for weight management. They have predominantly they cause medullary thyroid carcinoma by causing C-cell hyperplasia. These things are all present. These are all, there is incidence of this medullary thyroid carcinoma in GLP-1 analogs, but their incidence is very few. In a French study, it was found that only around the incidence of this medullary thyroid carcinoma and other types is only around 1% of the total patients who have been prescribed with long-term GLP-1 analogs, which is very low. Hence, we can use even though there is a small risk is present, the benefits are much more than that of the risk, and it is the risk of thyroid carcinoma is very few that is less than 1%. So, if in clinical practice, if there is no family history of thyroid cancer, we can go ahead with our GLP-1 analogs. In concluding points, clear your doubts only with your doctor than with your internet. Don't search for medical disorders in the internet without prior knowledge. Consult your thyroid specialist for your doubts regarding thyroid before coming to any conclusion. Yes, thank you.